Okay, it looks like it's 1 o'clock, top of the hour. Thank you everyone for joining us today to our webinar, and Happy New Year to everyone that's on the call. A couple quick things before we get started. You can submit your questions throughout the webinar via the chat function, and we'll try to get to those at the end. And your certificates should be available Friday by logging into your account. Dr. Eig, if you'd like to get started, go right ahead.
Thank you, Kim, and thank you to Medela for asking us to speak today, and thanks to you all for joining us today. Good afternoon to most of you, unless you're on Pacific time, so good morning to those of you who are out there. Bonnie and I are very, very happy to be here today. We represent the Maryland Patient Safety Center, and I'll tell you a little bit about the Patient Safety Center before we get into the topic today of racial disparities in maternal health outcomes. That is something we care passionately about. That is a part of the state health plan in the state of Maryland, and in fact is part of a national endeavors to improve maternal health outcomes, and especially to reduce the racial disparities that have existed for a while and have actually grown larger over the last several years. So I will start. My name is Blair Eig. I am the president of the Maryland Patient Safety Center. I am a pediatrician by training and have experience both in primary care and for 20 years as the chief medical officer for a hospital and health system in Maryland. We'll go to the next slide and we'll talk a little bit as introduction about the Maryland Patient Safety Center. First of all, for continuing education purposes, neither Bonnie nor I have any potential conflict, actual or potential conflicts of interest in relation to this presentation. We work for a nonprofit, nobody else. So Bonnie, next slide, please. So the Maryland Patient Safety Center is the state of Maryland's designated patient safety center. We were formed by an act of the Maryland legislature about 17 years ago. And every 5 years, the state designates the Patient Safety Center, and we've been it since it was originally formed. We are an independent nonprofit, a small nonprofit. We are not owned by the state. We're not owned by the State Hospital Association, which is the usual method in most states. In most of the states you're in, it's one of those two. We're a little different. We're independent, but we work with both the Hospital Association very closely and, of course, with the state. Our mission is keeping Maryland healthcare safe. It's very simple, but to us profound because it's really important for us. We've got 49 member facilities. Most of those are the hospitals across the state. There are about 50 hospitals in Maryland, but also some long-term care and other healthcare organizations are members. We work closely with state agencies to align our activities and our goals, and one of them we're talking about today. Reducing severe maternal morbidity is a state health goal in the state of Maryland. We develop statewide programs and do a lot of collaboratives, again, especially with hospitals and other organizations, most recently long-term care, to try to affect outcomes in patients and reduce errors and hazards that patients encounter in the healthcare system. We have 2 annual patient safety conferences. We give out patient safety awards for safety solutions that our members submit to us. And we do a lot of safety education, both used to be a lot in person, and now almost all of it is online, both synchronous webinars and seminars and asynchronous e-learning that we now have gotten into during the pandemic. Also, and not certainly one of the most important things we do, is we are a patient safety organization under the federal government. And we have patient safety officer forums for our state hospital patient safety officers on a regular basis, including safe tables where they can discuss anything. And we provide patient safety reporting for several of our members. The next slide, please. So our current major initiatives, and these change depending upon what the state needs, are our clean collaboratives, initially in hospitals and now in long-term care, where we try to reduce contact diseases, infectious diseases like Clostridium difficile and E. coli, so that we can make, obviously, the hospitals and the long-term care safer for our patients. We also have Caring for the Caregiver, which is we do in conjunction with the Armstrong Institute for Patient Safety at Johns Hopkins, which is peer support for healthcare staff in times of stress. And boy, the last 2 years have been stressful. Not only the pandemic and the risks associated with that, but all of the staffing issues that we've all seen across the country. We certainly have seen it in Maryland. And so there's a lot needed in terms of supporting staff through this so we don't lose more staff members. We have our Caring for the Caregiver program, not only in a majority of the hospitals in Maryland, but in more than half of the states across the country now. And the program continues to grow as health organizations realize that they need to provide staff with support during times of stress. Finally, and over the last 2 years, we've gotten more involved in healthcare equity. Initially, it was COVID vaccine hesitancies in communities and staff of color, where we partnered with the Maryland Hospital Association to try to counsel hospitals and other health providers in reaching out to their communities and their staff of color. We had a big disparity, a big gap in immunization initially, and that has narrowed significantly over the last 2 years. So we're proud to have been a part of that. And now, in terms of disparities in the incidence of severe maternal morbidity in women of color, this is true across the United States, but very true in Maryland. Black women are much more likely to either die or have a complication of pregnancy than white women in the United States and in Maryland. And we want to reduce that disparity and reduce severe maternal morbidity, complications of pregnancy overall. So now I'll turn it over to Bonnie, who will talk about some of the national efforts regarding severe maternal morbidity and those racial disparities that we see, and also a little bit about Maryland, and then towards the end, come back to me about what the Maryland Patient Safety Center is doing and plans to do over the next couple of years regarding this. So Bonnie, let me turn it over to you.
Thanks, Blair. Oh, I've got an echo going. I don't know how to get rid of that. Anyway, can you guys hear me?
It might be better.
What is it?
If Blair mutes,
it
might be better.
Okay. Much better. All right. So as Blair said, I'm going to start off by talking about what's going on nationally. And disparities in healthcare have been with us for a long time, but our recent experience with the pandemic and racial justice movement have really highlighted this for us. The pandemic showed us through data analysis that people of color were experiencing higher rates of death associated with COVID. And this was forcing us to ask ourselves why. Along with that was the racial justice movement that was sort of reinvigorated by the deaths of George Floyd, Breonna Taylor, and some others that highlighted systemic racial inequities in our country and also within the healthcare system. And the issues around the vaccine hesitancy taught us that the issues of trust in the healthcare system due to events that had occurred, not that long ago, were still sensitive issues in communities of color. So this issue of disparities in healthcare among races is not new, but it's sort of been brought to the surface as a result of these two movements specifically, or events. So in the United States, as Blair mentioned, we have data to support some disturbing facts for us. Despite continued advancements in medical care, maternal mortality and morbidity and preterm births continue to rise in the United States. And our rates are far higher than those in other similar countries. And people of color in the US are at an even higher risk for poor infant health and maternal health outcomes. So today we're going to be focusing on the maternal health outcomes for women of color. The disparities are the most profound we have found in our research for Black women. So much of what Blair and I are going to talk about today are related to women of color. There are other races, like we see in some areas, Native American people, but specifically Black women are really seeing a significant disparity. So a lot of what we will talk about is related to Black women. So as Blair said, Black women are more likely to experience a pregnancy-related death than white women. And I have two sources here. One is the National Partnership for Women and Families that says 3 to 4 times more likely to experience a pregnancy-related death than white women. But the CDC site states 2 to 3 times more likely. So I wanted to provide you with both sets of data, and in your states, that number may vary. In Maryland, we do experience 3 to 4 times more likely for a Black woman to die. Black women also experience more maternal health complications than white women. And then this statistic was a new one to me in preparing for this conference, was that Black serving hospitals provide lower quality maternity care. And so I dove into that a little bit because I was like, what does that statement exactly mean? And what I learned is that 75% of Black women give birth at hospitals that serve predominantly Black populations. And then in those hospitals, many of you that on this call, you're working in maternal and infant health, know that there are maternal health metrics, quality metrics that we all have to report on. And those hospitals have lower quality maternity care metrics. So things like C-section rates, early elective deliveries, non-elective C-sections, and maternal mortality. Those types of metrics, we're seeing this further disparity. It doesn't mean that necessarily the individuals that are providing the care, that there's some sort of substandard care going on, but there's a disparity going on in hospitals that are Black serving. So that just feeds into some of the things that we'll talk about later, and activities that we need to take a look at as healthcare clinicians serving this population. I have the source there if you want to look that up. If you just put into like a Google search, the National Partnership for Women and Families, that issue brief for April 2018. And then the CDC has a nice infographic on this topic. So the CDC on their website does have some data for us, and I wish, I always think their dates bother me, but it takes them a long time to scrub the data and all of that. So the most recent graph on this that is on the CDC website is this 2007 to 2016. But this data confirms that there's a significantly higher pregnancy-related mortality among Black and American Indian and Alaska Native women in the United States. And if you look at the time periods, they've got it, 2007 to 2008, 1 year gaps. And if you look, The navy blue is the Hispanic population, and that's kind of stayed flat over these years. And then the light blue is Asian or Pacific Islander, and that's actually come down a little bit if we could draw an imaginary trend line there. So that's looking a little better, but is it statistically significant? Probably not, but it's flat to slightly decreased. And then the American Indian Alaska Native is the lighter purple. And that has gone up over the years. And then the dark purple is Black women. And then that sort of in between medium blue is white women. So there's a significant gap, a huge gap between white women and Black women and American Indian or Alaskan Natives in this slide. So what are we doing about it? You know, it's one thing to have all this information and all this data, but is there anything happening nationally? And there is. Many of you have probably heard of this Momnibus Act of 2021, the Black Maternal Health Momnibus Act of 2021. That, you know, probably you had a general knowledge that it's, you know, targeting, doing some things to decrease these gaps and to improve the healthcare, maternal health care that we provide to our Black moms in the country. So what's in it? I wanted to know. And so this, I've listed this, I'm not going to read this whole thing, but I've included it so that you would have it as a resource. But it's got 12 points. So I'm just going to show you the other slide. And I did put a link there so you could go into this later. But if you look at it, it's a whole lot. It's a huge act that would provide funding for a number of efforts, ambitious efforts, if we look at them, to decrease the disparities in the healthcare that we're seeing and the maternal health disparities. And the honest truth, Blair says this to us all the time, if we fix things for Black moms, we'll fix things for everyone. So these are some funding sources that, you know, are targeting the disparity issue, but they're going to improve care, maternal health care for everyone. So just looking at it, we know that there are social determinants of health that are influencing this disparity, access to care, things like that, things that are outside of the organizational, you know, things that hospitals could take a look at, but, you know, they're providing acute and episodic care. But funding to work with organizations, funding to improve data collection and processes. You know, we learned in one of our efforts, you know, things that we're looking on that we don't necessarily know, like in our patient experience surveys, patient satisfaction surveys, often the question of race, or usually the question of race, isn't asked. So we can't even take a look at how the patient experience is different or not, because we're not asking certain questions like that. Providing some support for mental health conditions and substance use disorders. Several years ago, Maryland Patient Safety Center was doing some work with neonatal abstinence syndrome. We did a 2-year statewide collaborative on that. And we learned that the resources for opioid use disorder for pregnant women and women with children were really lacking in our state. And so you may see that in your facilities or and within your state too, are there support services for women with substance use disorder or mental health conditions? Maternal health for incarcerated moms and improving that health care and the care delivery that they get. And then on and on. These are some really ambitious activities, and it's pretty comprehensive. So you can also go and track how this is moving along. I'm not a health policy person. I'm a nurse. Funny, Blair talked about what he is. I am a nurse, but I was a surgical telemetry nurse clinically. But working in the patient safety center arena, I've gotten to know the maternal health folks in our state pretty well because we've done a lot of work there. But if you go to tracking a bill, I think it's called, I'll find it in my notes and provide that to you, but you can track how this bill is moving along. So there have been some support bills that have been introduced that support some of this, but this as it is, if you're like me, I take a look at this and go, this thing's going to change probably 20 times before it gets approved. But it'll be interesting to watch how it goes through. So what else? The CDC has introduced a campaign called the Hear Her Campaign. And one of the things that we have learned in our work is that many women who have experienced an adverse event during their maternal health experience often report, some of the ones that have spoken out and provided us with videos and advocates, that they complained about having symptoms of something going on and they felt like they weren't being heard. So this kind of takes off on that. I'm going to click onto this so you can see the site. This is the CDC site on the Hear Her campaign, and it's just chock full of resources and information. Here's a video on it, and a number of, information and educational tools that are available to you for free. So what it does, though, is it works to alert everyone, the women, their partners and friends, us as healthcare providers, what the urgent maternal warning signs are. A lot of times the women are coming in and reporting symptoms, but they're not being related to the pregnancy, to the postpartum period, and it's just not being taken as an urgent sign that should be followed up on. And Blair will talk a little bit about that specifically in some of the work that we're doing. But you can click here to learn more about the campaign, and the resources are in different languages and what the campaign goal is. So now I need to get back to my slides. Excuse me. So that CDC Hear Her campaign is, what I love about it is that it provides a number of tools and resources that you can use in your organizations, in your state, and in your education with your patients, with your friends, with your family, about early warning signs and things that people should be concerned about. Then the other thing that happened recently on December the 7th was Vice President Kamala Harris had what they called a Maternal Day of Action Summit. And her quote there kind of resonated with me because of the whole hearing thing. On this day of action, may the women of our nation know, I hear you, we hear you, and we are here to take action. So they had this summit on December the 7th at the White House, which that alone put some emphasis on the fact that the White House was taking this issue seriously. So, as I said earlier, our country, women are more likely to die in our country than they are in some other countries of similar industrialization, etc. So this day of action was there, and I live literally 20 miles from Washington, D.C., but I wasn't invited. So I read up about what was going on there. And so I was like, all right, what actions came out of this? What did they decide to do as a result of this day of action? And there were a number of things that came out. And like I mentioned, there were some bills that have been signed recently that help support the momnibus thing. But what were the actions that came out of this day? So once passed, there is another act called the Buildback Better Act that will invest over $3 billion in new maternal health funding. And this is the focus of that funding. I can't even imagine what $3 billion looks like, but it feels like a lot of money. But there is growing and diversifying the perinatal nursing and doula workforce. There are studies out there that doulas, the presence of a doula does impact outcomes for women. Supporting the National Birth Center on Birth Defects and Developmental Disabilities, funding for maternal mental health research at minority serving institutions. And we mentioned them before, that option, that data before. Looking at the data collection and maternal health risk monitoring, and then addressing substance abuse disorders that impact maternal health. In Maryland, the number 1 cause of maternal death in the first year after delivery is opioid use disorder or overdose. And then improving postpartum coverage and coordinating care. And this is a huge effort because often in most states, the Medicare coverage or Medicaid coverage ends at 6 weeks. And so we know that, many of the complications postpartum occur beyond that. And so I don't know if anybody's on the call from Illinois, but Illinois is the first state that has extended postpartum coverage to all pregnant women under Medicaid. And the administration, as a part of this day of action, invited all states to change their Medicaid coverage to be extended beyond the immediate postpartum period. So lots of funding came out of that and situations, but again, it's an act that's been put forth. And then the other thing that's not listed on this particular slide is the funding $12 million in additional funds for maternal obstetrics care in rural communities. HRSA, the Health Resources and Services Administration, is doing some funding for a program called Rural Moms, and that will, for the first time, applicants, they'll be required to focus on populations that are suffering from poorer outcomes, health disparities, and other inequities. So there's written into getting that funding that there will be actions to look at the disparities. So a lot of attention and a lot of potential funding is being driven on a national level to helping us with this issue. So that brings me to, so I'm like, okay, that's really high up, and that's what's happening on a national level. But what do we do about where we live, what's happening around us? And, in a state like mine, like what's happening. So what are the efforts that are going on? And I'm sure I'm just going to give you a highlight of a few of the efforts that are going on in our state. And I'm sure there are efforts similar going on in your states. So one of the things that Maryland has is something called the Maryland Perinatal Neonatal Quality Care Collaborative. And many states, for 13 years, the Maryland Patient Safety Center was the facilitator of this particular effort. And it's now being managed by another, the grant for it went to another organization. But many organizations like this exist, state organizations across the country. Not every single state has a perinatal quality collaborative that is just focused on efforts in maternal health, but many do, and more do than don't. But that's one effort. Our state quality collaborative right now is looking at maternal hypertension, and I think it's antibiotic stewardship. Blair will have to, when we get he unmutes and talks, he can correct me. I always get the infant one wrong. So that's one effort. Are they looking specifically at healthcare disparities? No, but they are an entity that can help support the efforts to improve maternal health. The other one, Maryland has a House Bill 837 that requires that implicit bias training and study be in every birthing hospital in the state. Maryland has 32 birthing hospitals, meaning 32 hospitals of labor and delivery, and it requires that every 2 years, the staff in maternal health units have implicit bias training. We are seeing this expanded to healthcare providers throughout hospitals, so it's not an issue just for maternal health units, as we know. The challenge about this is that we are started to collect some data. Is there any proof that implicit bias training changes the disparities? Does it improve things? And we don't know the answers to that yet, but our state legislature started with maternal health units and is now expanded that to all hospital staff. The other thing, I think most states have a maternal mortality review committee where they look at all of the maternal deaths and do, like a root cause analysis to see what happened. And this is where we get our data that, the number one cause of death, maternal death in Maryland is overdose. So it allows us to take a look at where our efforts should go in each individual state. And it provides you, if any of you have done a root cause analysis and looked at an adverse event, it provides you with sometimes information you just didn't even know was at play there. So Maryland does have a maternal mortality review program. And then this is new as of January 5th, if you can read that little microscopic date on there, we just received a 3-year, $1.1 million CDC grant to address maternal mortality statewide. So states have the opportunity to apply for funding to develop programs and create projects that are targeted to some of those things, those action items that I listed that are coming out of the Omnibus Act and things like that. There are other opportunities to help support that. So Maryland has been really aggressive or assertive, if you will. I'd say assertive in applying for funding to try and deal with this issue. The other big initiative that's going on is a HRSA grant. It's a state maternal health innovation program called the state MHI. It's funded by HRSA, and HRSA awarded 3 years ago 9 grants that totaled that big number there to assist states in addressing disparities in maternal health and in improving maternal health outcomes. And the specific emphasis was to be on prevention and reducing maternal mortality and severe maternal morbidity, and addressing the issue of disparities. Maryland applied for that grant through the Johns Hopkins Bloomberg School of Public Health, and Maryland was awarded $10.3 million 3 years ago. So it's a 5-year grant for all of these states that are listed. And we just began year 3 on October 1st, as did all of us. All of our states that you see listed there together began that process on October 1st. So we're in year 3. So we got 2 more years of this grant. And I bring this up because it's a lot of money, and the Maryland project, as is many of these, and these 9 states are working together almost like collaboratively. The projects are different, but they're sharing some of their resources, and it's a multi-pronged project that we called MD Mom. So MD Mom is the name of the Maryland Maternal Health Innovation Program. And MD Mom pulled in partners from 4 different entities. And to give you just sort of an overview, I'm going to take you to the MD Mom site. And so this is the site, and what MD Mom is doing is creating a severe maternal morbidity dashboard for the state. It's providing education. It's working with the hospitals, the birthing hospitals, to learn about their performance and how they're doing. And because that legislature that I mentioned about the implicit bias training came out right as we were applying for this, that was written into this grant, that the MD Mom program would provide that training to maternal health hospitals. So there is a hospital initiative, and because of the Maryland Patient Safety Center's longtime relationship with the birthing units in the state through our work with the Perinatal Quality Collaborative, they partnered with us too, because we had the relationships with the hospitals and had done quality collaboratives. We did neonatal abstinence syndrome. We reduced the C-section rates. We reduced early elective deliveries. We had done a number of statewide projects like that for several years. And so we're helping to facilitate the implicit bias training. We are also going to provide training to the maternal health units on opioid use disorder and pregnancy, and then also on how to do quality improvement initiatives in their organizations to take a look at interventions that will work. So the training, if you looked on and each one of those states that I mentioned, you could probably Google their maternal health innovation program and see what they're doing. But there's a number of resources here that you don't have to be in Maryland to take a look at. You can look at some of the webinars we've already done, etc. So that's the MD Mom program, big initiative in Maryland, and it will end. So we started year 3, so year 4 will be in 2023, and year 5 will be in 2024. Will end in 2025. The funding will be over, but we're hoping to make a big impact, not only on reducing the disparities in health and our maternal health outcomes, but in improving the health of maternal health in our state altogether. So I'm going to hand things over to Blair now, who's going to talk to you about specifically what the Maryland Patient Safety Center is doing now to deal with this problem.
Thanks, Bonnie. I'll first start off with just confirming what Bonnie had said about the Maryland Perinatal Neonatal Collaborative. The two initiatives are maternal hypertension and neonatal antibiotic stewardship. And that was confirmed by Katie Richards in the chat. Katie is the collaborative coordinator, so it's a shout out to Katie for the work that she's doing. So what are we doing at the Maryland Patient Safety Center? This is our graphic for the project that we've undertaken in terms of the healthcare disparities for the concerning Black women in the perinatal period. The numbers are what they are in Maryland. Black women are 3 to 4 times more likely to die from a pregnancy-related complication. Now, the way that's measured, just so everybody knows, nationally is within a year after birth. So during pregnancy or within a year after birth. So there can be what would seem to be unrelated complications that would cause death in that time period, but that's the way it's measured uniformly across the country. We also used this graphic for a Giving Tuesday campaign this past holiday season. Since we're a nonprofit, we were raising money to support this effort. We mentioned the 3 to 4 times more likely to die. In the next slide, you'll see severe maternal morbidity as measured by the CDC, and the rate is per 10,000 deliveries. And I guess it's pretty obvious. The yellow are Black moms, the red are white moms. The difference is a twofold, at least in Maryland and pretty much nationally, in terms of complications of severe complications of pregnancy in Black women versus white women, again, in Maryland and pretty much nationally. This shows you the data that we have in the state through 2019. The dotted lines, just so you know, are Maryland's projections that if we are successful with some of the work that we're doing, we want to see this decrease. We're projecting for this decrease because our goal is to reduce this by 20% over the next 4 to 5 years. There's a lot in that, but it's the right thing to do. And if we can improve especially the severe maternal morbidity in Black women, we're going to improve it for everybody. So it's the right place to go, and part, again, of our mission of keeping Maryland healthcare safe. So our program, if you go to the next slide, we recognize that there are many national and statewide programs that are already looking at severe maternal morbidity and mortality. And we realized that if we wanted to do this, again, it's a state health goal, we needed to partner with those programs. We did not need to be a separate entity doing something that they're doing, that we should partner and align what we're doing with what the other organizations are doing. So Bonnie already described the MD Mom program, a federally funded program that is addressing this in maternity units with maternity providers, with obstetricians, with midwives, and with nurses who work in maternity across the state. Where they are not addressing it is in non-maternity providers, in ERs, in clinics such as federally qualified health centers and primary care clinics across the state, with community health workers who work with both pregnant and postpartum moms. And we understood that what we came to realize was these are clinicians and health workers that work with these patients and see them. Sometimes they're seeing them and not the maternity providers. And to be able to address this issue across the board in healthcare, we wanted to address the education, understanding in the non-maternity providers, leaving the maternity providers to the MD Mom program. And this partnership with MD Mom and with the state has been wonderful. It's the right way to go, I think, and something that we've learned how to do through trial and error in the past, realizing that repeating what other people are doing is not the best way to attack a problem. So if you go to the next slide, talk about how we're doing this. We've partnered with the Maryland Hospital Association, our best friends, and we've convened an advisory group. The total number of members of the advisory group is 20, not all physicians. But we have on that physicians, obstetricians, nurses, expert in maternity and women's health care. And I should say not all the physicians are obstetricians. We have primary care and physicians, both internal medicine and family practitioners, who have concentrated on women's health care. Also policy experts and patient advocates across the state. The advisory group is chaired by two physicians, Dr. Nicole Rochester, who is a pediatrician, but also a healthcare advocate in the state of Maryland, and Dr. Salika Michelle, who is an OBGYN and also a patient advocate in the state of Maryland. And both have really, really well run this advisory group to get the most out of them. Everybody, again, is very passionate about this, and it's been wonderful to work with them over the last 8 months. What we've decided is that our education will concentrate on the sites where pregnant and postpartum women receive their care that aren't maternity units, especially ERs, which see a lot of postpartum women. Primary care, please excuse the reversing of letters. This should be FQHCs, not HQFCs, and federally qualified health clinics, and community health agencies. We recognize that a lot of women either don't see their obstetrician often enough or postpartum, but a lot of these other clinicians do see them. So in the next slide, we'll talk about what are our deliverables. So we have two introductory seminars. Dr. Rochester and Dr. Michelle have taken these two on for all of the sites that are engaged in this, and we're hoping it's going to be all of the ERs and many of the primary care clinics and FQHCs across the state that deal with especially a higher Black pregnant woman population. The introductory seminars are the complications of pregnancy for the non-maternity provider, and Dr. Michelle will be conducting that. What basics do you need to know to understand what these women are going through? And the healthcare equity that Dr. Rochester has already delivered for us in our programs on vaccine hesitancy. And she will talk about the history of Black women in healthcare in the United States and why there have been disparities, why there is some hesitancy in dealing with the healthcare system for Black women, and what we can do about that. What some positive steps we can take to both gain their trust, to hear them, and make sure that we are dealing with their issues successfully. We're also developing a video that's based on Team Steps. And if you don't know about Team Steps, I advise you to go to the AHRQ, the Agency for Healthcare Research and Quality, federal government site where it sponsors Team Steps. Team Steps is a team-based approach for healthcare teams to work together to provide higher quality, safer care to patients. It has the team listen to each other. It encourages members of the team, no matter who you are, to talk up if they're concerned about a safety or quality issue. This was grown out of a lot of the learnings in our airline industry and in the military, where speaking up about safety issues became vitally important to prevent a plane crash or some other disaster. We are learning this in healthcare. And so Team Steps does training like this, either live training or video training, to work with, again, healthcare teams to provide safer care. In our video, it's a short vignette of a postpartum woman, a Black woman, who has headaches, higher blood pressure, some swelling, signs of preeclampsia, who is not listened to by an ER doctor who may feel in a busy ER that this is just a stressed out new mom, and sends her home with follow-up at her OB at some undefined later date. We have the nurse speaking up and saying she does not feel safe with that, and maybe the doctor should call the OB. The doctor calls the OB and gives different advice where the patient's seen right away. We want teams to understand this, physicians, nurses, everybody seeing a patient, that if you don't know, you always can call your OB buddy to be able to get immediate advice and maybe immediate care and avoid that complication or more severe complication in the patient who is presenting before you. We've got an educational toolkit that's accessible via an app that gives algorithms for evaluation and care, so you can follow along if you're in an ER, for example, or in a clinic. Again, we will encourage calling that obstetrician or midwife or whoever's has cared for the patient for more advice. But there's also be some videos, some very short podcasts reviewing the various types of severe maternal morbidity, and links such as to that CDC Hear Her Campaign site. We'll have some marketing materials, posters, badge buddies, and wristbands, and this is a statewide effort that we're going to have to work on over the next year, where women, if they so choose, can wear a wristband, a colorful wristband, for the 6 weeks after their delivery, right up until that first postpartum visit, so that if they do show up in an ER, there's another sign that they've recently given birth. The next slide, please. So what are our outcomes? Well, we want 85% participation, at least in those seminars and the Team Steps video, for the patient-facing participants at the program sites. And again, we're hoping to get anywhere from 50 to 100 sites across the state over the next 3 years as we roll this out, especially ERs, but also the clinics, as I stated before, and the community health workers. We can measure the use of the toolkit. The app that we have is called ReadyWorks, and they can measure who is accessing it and how much it is being used, so we can see if our information is being accessed. And we are going to do pre and post education surveys of attitudes to see if we've had an effect, again, on awareness of both implicit and explicit bias, and on the various signs and symptoms of severe maternal morbidity. Finally, the ultimate goal, which is the state is again a state healthcare goal in Maryland, is reduction in the disparities and in the overall incidence of severe maternal morbidity in the state of Maryland. That's the hope that we have over time, but that's going to take several years to see. So we're going to use these other interim measures as we move along. I don't know, do we have another slide, Bonnie, or do we come to questions after this? Oh, that's our summary. And I could talk about this. As both Bonnie and I have discussed, we have some significant racial disparities. They exist. That's the data. There may be many reasons for that, and we can come up with lots of reasons, and they have been researched and they are being researched. But we need to address this, and we feel that addressing it with education, understanding, and with the encouragement of getting involved and calling for help is the best way to be able to reduce these disparities. Maybe most important is listen to the patient, understand what they're going through, and being able, again, to refer them to the person or the entity that can best care for them. The state level data and improvement efforts are all very important. That's what we talked about. The data is there. Your state has the same data that we have. It may look a little different in each state, but nationally, the numbers for Maryland aren't very much different than the national numbers. And these were our strategies to improve the maternal health disparities. A lot of other states are doing a lot of other things, but it all sort of focuses on the disparities, why the disparities are there, and what we can do with educating healthcare providers to be able to start reducing those disparities and reducing the overall incidence of maternal morbidity across the country. We are also hoping that learning through this project will help us with other disparities, because they do exist, for outcomes in diabetes, heart disease, and even with opioid abuse. We think if we can learn with this, there may be ideas that we've developed here that we can use in other efforts to reduce other problems that we see, complications, deaths, and morbidity associated with other healthcare problems that we look forward to attacking because we want to make everybody better. We want to keep Maryland and the whole country's healthcare safe. So I'll stop there. I assume there are some questions. We've got, about 6 or 7 minutes for questions, and maybe turn it back over to Kim for any of the questions that might have come in.
Thank you so much, Dr. Eig and Bonnie, for presenting that information to us and for the work that you are both doing on this subject. I love the idea of team steps style as well as the patient wristbands. I think those are both really great. Let's see, I did pop a link in the chat function for evaluations. So please fill those out for your nursing contact hours. And we're just looking to see, there aren't any current questions that have been unanswered in the chat as of right now. We do have about 5 minutes left for questions. And as a reminder, certificates will be available on Friday by logging into your account. And registration will be opening soon for our February 16th webinar. You can visit medilaeducation.com for registration for that once it's open, and also to get a copy of the 2022 webinar schedule. Just seeing if there's any other questions.
Kim,
Yes.
I will address one thing that we didn't address in presenting all that data, just for the audience so that they may understand one of the issues that we're dealing with. We do know that socioeconomic status, access to healthcare, education level of patients all has an effect upon the healthcare outcomes that we see across the country. Of interest with severe maternal morbidity, and especially with the disparity seen in Black women, this is not seen, the disparities not seen due to a lower education level, lower access to healthcare necessarily, or to income levels. Frequently, the data across the country has shown that the Black women who have a higher level of severe maternal morbidity are higher educated and are at higher income levels. Of note, they also tend to be older, and that may be the key here, because the older you are, and especially if you have any complicating other conditions such as diabetes or hypertension, the more likely you are to have a severe maternal complication. So it's just another point of data that's important to understand, that just because somebody is well educated, has a higher income, has access to healthcare, it doesn't mean that they're going to have a better outcome. And that we need to recognize, and we need to, again, listen to the patients, listen to the symptoms, and make sure that we're following up appropriately. And that's what we're trying to teach through this project.
There was a question a while back up on the scroll asking about the name of the grant, and I think they're talking about the HRSA Maternal Health Innovation Grant that had the 9 states involved. So if that's what the person was talking about, it's the HRSA Maternal Health Innovation Programs.
Thank you, Bonnie, for responding to that. I was going to ask that question. Great minds think alike.
Yeah.
There was one question. Someone said that they had recently retired from Mount Sinai Hospital in Chicago, and they're wondering how they can help current lactation consultants who they mentor before retirement to connect with grant money. So any input on that from either of you?
Well, so there are significant amounts of grant money that are being developed in some of these federal programs. But as we know, not everything's getting through Congress these days. When Bonnie mentioned what was the $3 billion built into the Buildback Better bill, and that's not passing the Senate right now, as we know. That's in the news every day. Hopefully that money will be there if and when it is finally passed. But many of these do have programs in terms of that will develop grants at a federal level for providing for care. And I am sure some of it includes lactation support. The state may also have it, so I don't know what Illinois has, but that shouldn't be too hard a search. Or if you have anybody who's connected with, again, the Department of Health in Illinois, they should know what grants are available. We know that in Maryland, money has been put into maternal care specifically by the legislature. They're again going to consider more money this year. I don't know, again, in Maryland, whether they've put money specifically into lactation support. I'm hoping they have. And there certainly will be efforts towards that every year, as there always are. But again, connection with your state health department is probably the best way to go there.
That's what I was going to suggest is, state health departments often have projects or have access to grants related to that.
Thank you so much, both of you, Dr. Eig and Bonnie, for that great information. It looks like we are at the top of the hour. It would be interesting if we could reconnect in 2025 to see the results of all of your hard work and see how it's paying off. I'm sure that we will have positive results when the results come back in that year. Thank you again for both taking the time to present for us this great information, and enjoy the rest of your day, everyone.
You too.
Thank you.
Bye-bye. Thanks for having us.